Good morning, dear students. Today we start discussing your topic about features of the diagnosis of internal disease in the elderly and senile age. The pattern of patient admitted to internal medicine wards has dramatically changed in the last 50 to 30 years. The internist used to see patients mainly complaining of illness affected only one organ or apparatus. They had been trained in medical school and during postgraduate specialization to acquire a broad knowledge and a holistic approach to diagnosis and treatment in order to efficiently tackle the varied clinical problems presented by relatively young patients, usually suffering from a single disease. This situation changed in the last part of the 20th century when tremendous developments in health technology made it difficult for most internists to follow progress and become proficient in the advanced that marched at a fast and often overwhelming pace. This led to bursts of development of various subspecialists of internal medicine, such as cardiology, gastroenterology, pulmonology, and others that had tremendous impetus and increasing popularity in the community and hence among healthcare planners. The growth and appeal of subspecialists was paralleled by a period of uncertainty about the role and mission of general internal medicine, and in mainly instance hospital medical wards had to yield space to specialized units. What has dramatically altered this pattern in the last few years? The fact that the internists had to deal increasingly more with the management of elderly people with multiple chronic disease rather than with young people with single disease. Elderly people are now the most rapidly growth part of the patient population worldwide, thanks to more focus on primary prevention of diseases and improvement in healthcare for the young ill patient. A century ago, one individual in 20 was age 65 years or over. Now one in 6 is, and by 2050 it is expected to be 1 in 4. Individuals age 80 years or more are the fastest growing section of the population and are expected to reach nearly 30% of the overall population in the richest nation by 2050. The progress of aging involves a continuum of changes in biological, functional, psychological, and social parameters that vary depending on genetic factors, age-related vulnerability, and difference in organ function and service reserves. Aging seldom comes alone. It is often accompanied by chronic or multiple diseases, comorbidity, disability, frailty, and social isolation. It is unusual for elderly patients to have only one disease affecting only one organ or apparatus. Even through, for example, acute pneumonia by the ultimate cause of hospital admission for an 80 years old woman, she may very often also complain of, for instance, concomitant diabetes, heart failure, osteoporosis, anemia, and hypertension. Organ subspecialists sometimes find it difficult to tackle all these different diseases, which are unlikely to be seen concomitantly in the younger patient. There are usually accustomed to caring for. Accordingly, the holistic approach of the internist to patients' healthcare has become increasingly more important, and the role and visibility of internal medicine has been magnified. Um, Multi-morbidity in the elderly has been estimated to range from 55 to 98% and is highest in the very old in women and individuals belonging to low social economic classes. Although multi-morbidity often simply involves the co-occurrence of two or more diseases. The distribution, combination, and development of different diseases need to be better understood, as well as the mechanisms to leading to the co-occurrence of disease and the natural history of multimorbidity. And in assessing the individual's attention must be paid to genetic and biological factors, lifestyles, socioeconomic determinants, and how these factors interact to determine multimorbidity. The lack of well-designed clinical studies recruiting these patients limits the availability of evidence-based information on the effect of multiple drugs on such clinically relevant outcomes as functional and cognitive decline, quality of life, adverse events, and mortality. Most clinical research projects in internal medicine still focus on the disease-oriented approach, which does not take account of the complexity and overlapping health and social problem of elderly patients. Despite this limitation, over the last few decades, many clinical care models and interventions have been developed and tested for patients with multimorbidity, especially in geriatric settings. The main age-related changes in organ system for body composition is progressive reduction in total body water and lean body mass, uh, or increase in body fat. Cardiac and peripheral vascular system effects of aging, heart changes, stiffening, reduced muscle strength, reduction in the intrinsic heart rate, atherosclerosis and loss of elasticity of vessels walls, prescription implications, higher systolic arterial pressure, increased impedance to left ventricle injection, left ventricle hypertrophy and interstitial fibrosis, reduced response to postural changes, increased heart rate. For central nervous system, effects of aging, increased sensitivity, decreased blood flow, decline in receptors and pathway. Prescribing implications, enhanced response to CNS engines, slow mobility, and voluntary motor activity, delirium. For gastrointestinal tract, effect of aging, decreased secretion of hydrochloric acid and pepsin, function in gastrointestinal motility, decreased gastrointestinal blood flow, a reduction in liver volume and blood flow. Prescribing implications, constipation, reduced absorption and metabolism of several drugs. Immune system, decreased immunity to disease, greater susceptibility to infections. Prescribing implication, increase in antibiotic use. Musculoskeletal system. Effects of aging: loss of muscle tissue, osteoarthritis, osteoporosis. Prescribing implications: increased use of analgesic and anti-inflammatory drugs, increased risk of falls and fractures. For renal system, is a reduction of renal mass and blood flow, decline in GFR. Prescribing implications: prolonged effects of drug poorly excreted by the kidney. Respiratory system, vital capacity and FEV may decline with age, increase rigidity of chest wall, reduce thoracic muscle strength and endurance. Prescribing implications: loss of strength and endurance of lung with some drugs. Sensory system, effects of aging: visual impairment, thinning and yellowing of the lens of the eye, hearing impairment, loss of sensitivity for high frequency tones and of discrimination of similar pitches, decline in the ability to taste and smell. Prescribing implications: reduced adherence to drug therapies. Aging refers to the inevitable, irreversible decline in organ function that occurs over time, even in the absence of injury, illness, environmental risks, or poor lifestyle choices. Uh, Initially, the changes in organ function don't affect baseline function. The first manifestation are reduced capacity of each organ to maintain homeostasis under stress. The cardiovascular, renal, and central nervous system are usually the most vulnerable. Disease interact with pure aging effects to cause geriatric-specific complications, particularly in the weak limb systems, even when those organs are not the primary ones affected by a disease. Typical examples are delirium, complicating pneumonia or urinary tract infection, and the falls, dizziness, syncope, urinary incontinence, and weight loss that often accompany many minor illnesses in older adults. Aging organs are also more susceptible to injury. For example, intracranial hemorrhage is more common and is triggered by less clinically important injury in older adults. The effects of aging must be taken into account during the diagnosis and treatment of older adults. Clinical should be not mistake pure aging for disease, mistake disease for pure aging, ignore the increased risk of adverse drug effects on weak limb system stressed by illness. Forget that older adults often have multiple underlying disorders, hypertension, diabetes, atherosclerosis, that accelerate their potential for harm. In addition, clinicians should be alert for disease and problems that are much more common among older adults. Diagnostic heart failure, Alzheimer's disease, incontinence, atrial fibrillation. This approach enables clinicians to better understand and manage the complexity of the disease that often coexist in older patients. Understanding the physical changes and geriatric-specific manifestation of disease that accompany advanced age is important to avoid the negative and prejudicial stereotypes about older adults that characterize ageism and can negatively impact patients' care and quality of life. Evaluation of older adults usually differs from a standard medical evaluation. For older patients, especially those who are very old or frail, history taking and physical examination may have to be done at different times, and physical examination may require two sessions because patients become fatigued. Early detection of problem can result in early intervention, which can prevent deterioration and improve quality of life, often through relatively minor, inexpensive interventions like lifestyle changes. Thus, some older patients, particularly the frail or chronically ill, are best evaluated using a comprehensive geriatric assessment, which include evaluation of function and quality of life, best administered by an interdisciplinary team. On average, older patients have six diagnosable disorders. A disorder in one organ system can weaken another system, exacerbating the deterioration of both and leading to disability, dependence, and without intervention, death. Multiple disorders complicate diagnosis and treatment, and effects of the disorders are magnified by social disadvantage and poverty, resource and poverty, and by functional and financial problems. Clinicians should also pay particular attention to certain common geriatric symptoms like delirium, dizziness, syncope, falling, mobility problem, weight of or appetite loss, urinary incontinence, because they may result from disorders of multiple organ system. If patients have multiple disorders, treatments, bed rest, surgery, drugs must be well integrated. Treating one disorders without treating associated disorders may accelerate decline. Also, careful monitoring is needed to avoid iatrogenic consequences. For example, with complete bed rest, older patient can lose 1 to 3% of muscle mass and strength each day, causing sarcopenia and sharply reduced mobility. And effects of bed rest alone can ultimately result in death. In this slide, 10 common chronic conditions for adults more than 65 years old. It's hypertension, high cholesterol, arthritis, ischemic coronary heart disease, diabetes mellitus, COPD, Alzheimer's disease, and dementia, depression, heart failure, and chronic kidney disease. Disorders that are common among older adults are frequently missed, or the diagnosis is delayed. Clinicians should use the history, physical examination, and simple laboratory tests to actively screen for disorders that occur only or more commonly in older patients. When diagnosed early, these disorders can often be more easily treated. Early diagnosis frequently depends on the clinician's familiarity with the patient's behavior and history, including mental status. Commonly, the first signs of physical disorders are behavioral, mental, or emotional. If clinicians are aware of this possibility and attribute these signs to dementia, diagnosis and treatment can be delayed. Patient's prescription, over-the-counter, and recreational drug, including marijuana, uh, should be reviewed frequently, particularly to look for drug interaction and use of drugs considered inappropriate for older patients. This review is especially important drug care transition when a reconciliation of drugs is required to eliminate duplication, missed drug and errors in dosage, and to identify drugs that may be no longer be needed. Occasionally, problems of older patients are related to neglect of abuse by their caregiver. Clinicians should consider the possibility of patient abuse and drug abuse by the caregiver is circumstances and findings suggest it. Certain injury patterns or patient's behavior are particularly suggestive, including frequent bruising, especially in difficult to reach areas, for example, middle of the back, bruises of the upper arms, bruises of the genitals, peculiar burns, unexpected fearfulness of caregiver in the patient. Attention to medical history is particularly important in older adults because the history of is often more complicated than in younger patients, and information may need to be gathered, gathered from a variety of sources. Often more time is needed to interview and evaluate older patients, partly because they may have characteristics that interfere with their evaluation. The following should be considered: sensory deficits, dentures, eyeglasses, or hearing aids, if normally worn, should be worn to facilitate communication during the interview. Adequate lighting and elimination of visual or auditory distraction also help. Under responding of symptoms, older patients may not report symptoms that they may incorrectly consider part of normal aging, like dyspnea, hearing or vision deficits, memory problems, incontinence, gait disturbance, constipation, dizziness, falls. However, no symptoms should be attributed to normal aging unless a through evaluation is done and other possible causes have been eliminated. Unusual manifestation of a disorder in older adults. Typical manifestations of a disorder may be absent. Instead, older patients may present with non-specific symptoms like fatigue, confusion, weight loss. Functional decline as the only manifestation. Disorders may manifest slowly as functional decline. In such cases, standard question may not apply. For example, when asked about joint symptoms, patient with severe arthritis may not report pain, swelling, or stiffness, but if asked about changes in activity, they may, for example, report that they no longer take work or volunteer at the hospital. Question about duration of functional decline can elicit useful information. Identifying people when they have just started to have difficulty doing basic activity of daily living or instrumental activities of daily living may provide more opportunities for interventions to restore function or to prevent further decline and thus maintaining independence. Difficulty recalling. Patient may not accurately remember past illnesses, hospitalization, operations, and drug use. Clinicians may have to obtain this data elsewhere. Fear. Older adults may be reluctant to report symptoms because they fear hospitalization, which they may associate with dying. Age-related disorders and problems. Depression, common among older adults who are vulnerable and sick. The cumulative losses of old age and discomfort due to disorders may make older adults less apt to provide health-related information to clinicians. Patients with impaired cognition may have difficulty describing problem, impeding the physician's evaluation. A clinician's knowledge of an older patient's everyday concerns, social circumstances, mental function, emotional state, and sense of well-being helps orient and guide the interview. Asking patient to describe a typical day elicits information about their quality of life and mental and physical function. This approach is especially useful during the first meeting. Patients should be given time to speak about things of personal importance. Clinicians should also ask whether patients have specific concerns such as fear of falling. The resulting report can help the clinician communicate better with patient and their family members. A mental status examination should be done early in the interview to determine the patient's reliability. This examination should be considered tactfully so that the patient does not become embarrassed, offended, or defensive. Routine screen for physical and psychological disorders should be done annually, beginning at age 65. Often verbal and non-verbal clues can provide information as for the following. Depression. Older patient may omit or deny symptoms of anxiety or depression but betray them by lowered voice, subdued enthusiasm, or even tears. Uh, Physical and mental health. What patients say about sleep and appetite may be revealing. Weight gain or loss. Clinicians should note any changes in the fit of clothing or dentures. Unless mental status is impaired, a patient should be interviewed alone to encourage the discussion of personal matters. Clinicians may also need to speak with a relative or caregiver who often gives a different perspective on function, mental status, and emotional state. These interviews may be done with the patient absent or present. The clinician should ask the patient's permission before inviting a relative or caregiver to be present and should explain that such interviews are routine. If the caregiver is interviewed alone, the patient should be kept usefully occupied filling out a standard assessment questionnaire, being interviewed by another member of in the interdisciplinary team. If indicated, clinicians should consider the possibility of drug abuse by the patient and patient abuse by the caregiver. When asked patient about their past medical history, a clinician should ask about disorders that used to be more common, rheumatic fever, poliomyelitis, and about outdated treatments, pneumothorax therapy for tuberculosis, mercury for syphilis, a history of immunization like COVID, influenza, pneumococcus, tetanus, adverse reaction to immunizations, and skin test results for tuberculosis is needed. If patients recall having surgery but don't remember the procedure or its purpose, surgical records should be obtained if possible. Clinicians should ask questions designed to systematically review each body area or system to check for other disorders and common problems that patients may have forgotten to mention. Drug history. The drug history should be recorded and a copy should be given to patient or their caregivers. It should contain drug use, dose, a dosage schedule, prescriber, reason for prescribing the drugs, prescribed nature or any drugs allergies. All drugs and substances used should be recorded, including topical drug, which may be absorbed systematically, over-the-counter drug which can have serious consequences if overused and may interact with prescription drugs, dietary supplements, medical herbs preparation because many can interact adversely with prescription and over-the-counter drugs, alcohol, caffeine, other recreational drugs. Patients or family members should be asked to bring in all of the above drugs and supplements at the initial visit and periodically thereafter. Clinicians can make sure patients have their prescribed drugs, but possession of these drugs does not guarantee adherence. Counting the numbers of tablets in each while during the first and subsequent visits may be necessary. If someone other than a patient administered the drugs, that person is interviewed. Patients should be asked to show their ability to read labels, often printed in small type, often open containers, especially the child-resistant type, give themselves treatments using a device such as an inhaler and recognizing drugs. Patients should be advised not put their drugs into one container. Patients who smoke tobacco should be counseled to stop, and if they continue, not to smoke in bed because older adults are more likely to fall asleep while doing so. Patients who use e-cigarettes and vape products should be warned about the risk of nicotine addiction and pulmonary injury. Patients who use recreational drugs should be considered counseled about risk of addiction and possible interaction with prescription and other drugs. Patients should be checked for signs of alcohol use disorders which are underdiagnosed in older adults. Such signs include confusion, anger, hostility, alcohol odor on the breath, impaired balance and gait, tremors, peripheral neuropathy, and nutritional deficiencies. Screening questionnaire and questions about quantity and frequency of alcohol consumption can help. The short Michigan Alcohol Screen Test geriatric version is a 10-question test designed for people 65 and older. It is usually preferred to other screening questionnaires that were not designed for older adults. 2 or more yes responses suggest the possibility of an alcohol use disorders. Nutrition history type, quantity, and frequency of food eaten are determined. Patients who eat less than 2 meals a day are at risk of undernutrition. Clinicians should ask about the following: any special diets or self-prescribed fat diet, intake or dietary fiber, and prescribing of over-the-counter vitamins, weight loss and change of fit in clothing, amount of money patients have to spend on food, accessibility of food stores and suitable kitchen facilities, variety and freshness of food. The ability to eat is evaluated. It may be impaired by xerostomia or dental problems, which are common among older adults. Decreased taste or smell may reduce the pleasure of eating, so patients may eat less. Patients with decreased vision, arthritis, immobility, or tremors may have difficulty preparing meals and may injure or burn themselves when cooking. Patients who are worried about urinary incontinence may inappropriately reduce their fluid intake, increasing their risk of dehydration. Mental health problems may not be detected easily in older patients. Symptoms that may indicate a mental health disorders in young patients, like insomnia, changes in sleep patterns, constipation, cognitive dysfunction, anorexia, weight loss, fatigue, preoccupation with bodily function, increased alcohol consumption may have another cause in older adults. Sadness, hopelessness, and crying episodes may indicate depression. Irritability may be the primary affective symptoms of depression, or patient may present with cognitive dysfunction. Generalized anxiety is the most common mental disorders encountered in older patients and often is accompanied by depression. Patient should be asked about delusions and hallucination past mental health care, including psychotherapy, institutionalization, and electrocognitive therapy, use of psychoactive drugs, and recent changes in circumstances. Many circumstances, recent loss of a loved one, hearing loss, change in residence or living situation, loss of independence, may contribute to depression. Patients' spiritual and religion preference, including their personal interpretation of aging, decline, health, and death, should be clarified because these preferences and viewpoints impact their goals of care and quality of life. Whether patient can function independently, needs some help with basic activity of daily living, or instrumental activity of daily living, or need total assistance is determined as part of co- comprehensive geriatric assessment. Patients should be asked open-ended questions about their ability to do activity, or they may be asked to fill out a standard assessment instrument with questions about specific uh, activities of daily living and instrumental activities of daily living. Clinicians should obtain information about patients' living arrangements, particularly where and with whom they live, alone in an isolated house, in a busy apartment building, accessibility of their residence, and what models of transportation are available to them, ownership of a smartphone and ability to use it to access ride sharing, food delivery, or and other supportive services should also be assessed. Such factors affect their ability to obtain food, health care, and other important resources. A home visit, also difficult to arrange, can provide critical information. For example, clinician can gain insight about nutrition for the refrigerator's contents and about multiple activity daily living from the bathroom's condition. The number of room number and type of phones, presence of smoke and carbon monoxide detection, and condition of plumbing and heating system are determined. It is uh, the availability of elevators, stairs, and air conditioning. Home safety evaluation can identify home features that can lead to falls, and a solution can be suggested. Having patients describe a typical day, including activities such as reading, television viewing, work, exercise, hobbies, and interactions with other people, provide valuable information. Clinicians should ask about the following: frequency and nature of social contact, both in version via telephone and online, family visits, and religion or spiritual participation, driving and availability of other forms of transportation, including ride-sharing service, caregivers and support system that are available to the patient, the ability of family members to help the patients, their employment status, their health, traveling time to the patient's home, the patient attitude toward family members, and their attitude toward the patient, including their level of interest in helping with willingness to help. Marital status of patient is noted. Question about sexual practice and satisfaction must be sensitive and tactful but throughout. This number and sex of sex partners are determined and risk of sexually transmitted infection is evaluated. Many sexually active older people are not aware of the increasing incidence of uh, sexually transmitted infection in older adults and don't follow or even know about safe sex practices. Patients should be asked about educational level, job health, known exposure to toxins, and current and past hobbies. Economic difficulties due to retirement, fixed income, or death of a spouse or partner are discussed. Financial or health problem may result in loss of a home, social status, or independence. The physical examination of the older adults should include all mirror system, but with particular attention to areas of concern identified during the history. Observing patients and their movements, like walking into the examination room, sitting in or rising from a chair, getting on and off an examination table, take off or putting on socks and shoes, can provide valuable information about their function, their personal hygiene, state of dress, cleanliness, odor, may provide information about mental status and their ability to care for themselves. If patient become fatigued, the physical examination may need to be stopped and continued at another visit, or the patient may require additional time to undress to transfer to the examining table. They should not be rushed. The examining table should be adjusted to a height the patient can easily access. A footstool facilitate mounting. A frail patient must be not left alone on the table. Portions of the examination may be more comfortable if patients sit in a chair. Clinicians should describe the general appearance of patients. If they are examined at bedside, use of protective bedding or protective mattress, bed rails, resistant urinary catheter, or adult Deeper should be noted. Weight should be recorded in each visit. During measurement, patient with balance problem may need to grab bars placed near on the scale. Height is recorded annually to check for height loss due to osteoporosis. Temperature is recorded. Hypothermia can be missed in the thermometer can measure temperature more than a few degrees lower than normal. Absence of fever does not exclude infection. Pulse and blood pressure are checked in both arms. Pulse is taken for 30 seconds and any irregular is noted. Because many factors can alter blood pressure, it is measured several times after patients have rested more than 5 minutes. Blood pressure may be overestimated in older patients because their arteries are stiff. This rare condition, called pseudohypertension, should be suspected of dizziness develops after antihypertensives are begun or doses are increased to treat persistently elevated systolic blood pressure. All older patients are checked for orthostatic hypertension because it is common. Blood pressure is measured with patient in the supine position when after they have been standing for 3 to 5 minutes. If systolic blood pressure falls more 20 millimeters after patient stand or any symptoms of hypertension are detected, orthostatic hypertension is diagnosed. Caution is required when testing hypovolemic patients. A respiratory rate for older adults differs based on health and living situation. The normal respiratory rate for older adults living independently is 12 to 18 breaths per minute, whereas the rate for those needs long-term care is 60 to 25 breaths per minute. Initial observation include color, examination. Examination includes a search for premalignant and malignant lesions, tissue ischemia, and pressure injuries. In older patients, the following should be considered. Ecchymosis may occur readily when skin is traumatized, often on the forearm because the dermis things with aging. Uneven tanning may be normal because melanocytes are progressively lost with aging. Longitudinal ridges on the nail and absence of the crescent-shaped lunula are normal age-related findings. Nail plate fractures may occur because with aging and nail plate things. Black splintered hemorrhages in the middle of distal third of the fingernail are more likely to be due to trauma than to bacteremia. I think yellow toenail indicates onychomycosis, a fungal infection. Toenail borders that curve and down indicate ingrown toenail onychocryptosis. Within nails that scale easily, sometimes with a pitted surface, indicate psoriasis. Unexplained bruises may indicate abuse. Normal age findings may include the following: a brow that drop below the superior orbital rim, descent of the chin, loss of the angle between the submandibular line and neck, wrinkles, dry skin, thick terminal hairs or on the ears, nose, upper lip, and chin. The temporal arteries should be palpated for tenderness and thickening, which may indicate Giant cells arteriitis, suspicion of which requires immediate evaluation and treatment. Progressive descent of the nasal tip is a normal age-related findings. It may cause the upper and lower lateral cartilage to separate, enlarging and lengthening the nose. Eyes. Normal age-related findings include the following: loss of orbital fat. It may cause a gradual sinking of the eye backward into the orbit. Thus, enophthalmos is not necessarily a sign of dehydration in older adults. Enophthalmos is accompanied by dipping of the upper eyelid fold and slight obstruction of peripheral vision. Pseudoptosis, entropion, ectropion, arcos senilis. With aging, presbyopia develops, the lens becomes less elastic and less able to change shape when focusing on close object. The eye examination should focus on testing visual activity. Visual fields can be tested at the bedside by confrontation. Patients are asked to stare and their examiner so that the examiner can determine difference between their and the examiner visual fields. However, such testing has low sensitivity for most visual disorders. Tonometry is occasionally done in primary care. However, it is usually done by ophthalmologists or optometrists as part of routine eye examination or by ophthalmologists just when a patient is referred to them because glaucoma is clinically suspected. Ophthalmoscopy is done to check for cataracts, optic nerve or macular degeneration, and evidence of glaucoma, hypertension, or diabetes. Findings may be unremarkable unless a disorder is present because the retina's appearance usually does not change much with aging. In older patients, mild to moderate elevated intracranial pressure may not result in papilledema because cortical atrophy occurs with aging. Papilledema is more likely when pressure is markedly increased. Areas of black pigment or hemorrhages in and around the macula indicate macular degeneration. For all For older patients, an eye examination by an ophthalmologist or optometrist is recommended every 1 to 2 years because such an examination may be much more sensitive for certain common ear disorders like glaucoma, cataracts, retinal disorders. Ears. For external auditory canal is examined for circumvent, especially if a hearing problem is noted during the interview. If a patient wears an external hearing aid, it is removed and examined. The ear mold and plastic tubing can become plugged with wax, or the battery may be dead, indicated by absence of whistle when the volume of the hearing aid is turned up. To evaluate hearing, examiners with their face out of the patient's view whisper 3 to 6 random words or letters into each of the patient's ears. If a patient correctly repeats at least half of these words for each ear, hearing is considered functional for one-on-one conversation. Patients with presbycusis, age-related gradual bilateral symmetric and predominantly high-frequency hearing deficit are more likely to report difficulty in understanding speech than in hearing sounds. Evaluation with a portable audioscope, if available, is also recommended because the testing sound are standardized. Thus, this evaluation can be useful when multiple providers are caring for a patient. Patients are asked whether hearing loss interferes with social work or family functioning, or they may be given the hearing handicap inventory for the elderly screen version, a self-assessment to determine the effects of hearing loss on the emotional and social adjustment of older adults. If hearing loss interferes with functional of, or if the hearing handicap inventory for elderly screen versions scope is positive, they are referred for formal audiologic testing. Mouth. The mouth is examined for bleeding or swollen gums, loss or broken teeth, fungal infection, and signs of cancer, like leukoplakia, erythroplakia, ulceration, mass. Findings may include darker tints due to extrinsic stains and less translucent enamel, which occur with aging, fissures in the mouth and tongue that stick to the buccal mucosa due to xerostomia, erythromatous edematous gingiva that bleeds easily, usually indicating gingival or periodontal disorders. Bad breath possibly indicates oral disorders, caries, periodontitis, and other infection, or sometimes a pulmonary disorders. The dorsal and ventral surface of the tongue are examined. Common age-related changes include various veins of the ventral surface being migratory glossitis, geographic tongue, and atrophied papilla of the side of the tongue. In edentulous patients, the tongue may enlarge to facilitate chewing. However, enlargement may also indicate amyloidosis or hypothyroidism. A smooth, painful tongue may indicate vitamin B12 deficiency. Dentures should be removed before the mouth is examined. Dentures increase risk of oral candidiasis and resorption of the alveolar ridges, inflammation of the palatal mucosa, and ulcers of the alveolar ridges may result from poorly fitting dentures. The inferior of the mouth is palpated. A swollen, firm, and tender parotid gland may indicate parotitis, particularly in dehydrated patients. Pus may be expressed from Stenson duct when bacterial parotitis is present, and the infecting organisms are often staphylococci. Painful inflamed fissured lesions at the lip commissure may be noted in edentulous patients who do not wear dentures. These lesions are usually accompanied by a fungal infection. These temporomandibular joints. These joints should be evaluated for degeneration, osteoarthrosis, a common age-related change. These joints can degenerate as teeth are lost and compressive forces in the joint become excessive. Degeneration may be indicated by joint crepitus felt and the head of the condyle as patients lower and raise their jaw by painful jaw movement or by both. The thyroid gland, which is located in the front of the neck, wrapped around the trachea, is examined for enlargement and nodules. Carotid bruits due to transmitted heart murmurs can be differentiated from those due to carotid artery stenosis by moving this stethoscope up the neck. A transmitted heart murmur becomes softer, The bruit of carotid artery stenosis become louder. Bruits due to carotid artery stenosis suggest systemic atherosclerosis, whether asymptomatic patient with carotid bruits require evaluation of treatment for cerebrovascular disease in unclear. The neck is checked for flexibility, resistance to passive flexion, extension, and lateral rotation may indicate a cervical spine disorder. Resistance to flexion and extension can also occur in patients with meningitis, but unless meningitis is accompanied by cervical spine disorders, the neck can be rotated passively from side to side without resistance. All areas of the lungs are examined by percussion and auscultation. Basilar rails may be hard in the lungs of healthy person, but should not disappear after patients take a few deep breaths. The extent of respiratory excursion should be noted. The back is examined for scoliosis and tenderness, severe low back, hip, and leg pain with marked sacral tenderness may indicate spontaneous osteoporotic fractures of the sacrum, which can occur in older adults. In men and women, the breasts can be considered for annual examination, but there is not strong evidence of benefit, which limit the recommendations made by both the American Cancer Society and U.S. Preventive Service Task Force. If nipples are retracted, pressure should be applied around the nipples. Pressure events the nipples when retraction is due to aging, but not when it's due to an underlying lesion. Heart. Heart size can usually be assessed by palpating the apex. However, displacement caused by kyphoscoliosis may make assessment difficult. Auscultation should be done systematically. Rate regularity murmurs, clicks, and rips. Unexplained and asymptomatic sinus bradycardia in apparently healthy older adult may not be clinically important, and irregular rhythm suggested atrial fibrillation. In older adults, systolic murmurs heart at the base most commonly indicate aortic valve stenosis. Typically, its murmur is not hemodynamically significant, although risk of stroke may be increased. It peaks early during systole and is rarely part of the carotid arteries. Rarely, sclerosis of the aortic valve progress to hemodynamic significance and calcification. Also infrequent, aortic valve sclerosis is now the most common lesion, leading to symptomatic aortic stenosis and need for treatment. However, systolic murmurs may be due to other disorders which should be identified. Aortic valve stenosis. This murmur is contrast to that of usual aortic valve sclerosis, typically peaks later during systole, is transmitted to the carotid arteries and is loud, greater than grade 2. The second heart sound is dampened, pulse pressure is narrow, and the carotid upstroke is slowed. However, in older patients, the murmur of aortic valve stenosis may be difficult to identify because it may be softer, and second heart sound is rarely attitude audible, and narrow pulse pressures are uncommon. Also, in many older patients with aortic valve stenosis, the carotid upstroke does not slow because vascular compliance is diminished. Mitral regurgitation is murmurs. This murmurs is usually loudest at apex and radiates to the axilla. Hypertrophic obstructive cardiomyopathy. These murmurs intensifies when patients do a Valsalva maneuver. Diastolic murmurs are abnormal in people of any age. False heart sounds are common among older patients without evidence of cardiovascular disorders and are commonly absent among older patients with evidence of cardiovascular disorders. If new neurological cardiovascular symptoms develop in patients with a pacemaker evaluation for variable heart sounds, murmurs, and pulses, and for hypertension and heart failure is required. These symptoms and signs may be due to loss of atrioventricular synchrony. The abdomen is palpated to check for weak abdominal muscles, which are common among older patients and which may be predisposed to hernias. Most abdominal aortic aneurysm are palpable as a pulsative mass. However, they only their lateral wides and can be assessed during physical examination. In some patients, particularly thin abnormal aorta is palpable, but the vessels and pulsation don't extend laterally. Screening ultrasonography of the aorta is recommended for all older men who have ever smoked. The liver and spleen are palpated for enlargement. Frequency and quality of bowel sounds are checked, and the suprapubic area is percussed for tenderness, discomfort, and evidence of urinary retention. The anorectal area is examined externally for fissures, hemorrhoids, and other lesions. Sensation of the anal wing reflex are tested. A digital rectal examination to direct a mass structure tenderness or facial impaction is done in men and women. Facial occult blood testing is also done. The prostate gland is palpated for nodules, tenderness, and consistency. Estimate prostate size by digital rectal examination in inaccurate and size does not correct with urethral obstruction. However, a digital rectal examination may provide a qualitative estimate of prostate volume. Most professional organizations don't recommend digital rectal examination as a screening tool for prostate cancer, as the genital area should be examined for signs of sexually transmitted infection, other infection, and abnormalities. For bone manual pelvic examination, patients who lack hip mobility may lie on other left side. Postmenopausal reduction of estrogen leads to atrophy of vaginal and urethral mucosa. The vaginal mucosa appears dry and lack rugal folds. The ovaries should be not palpable. 10 years after menopause, palpable ovaries suggest cancer. Patients should be examined for evidence of prolapse of the urethra, vagina, cervix, and uterus. They asked to check for urine leakage and intermittent prolapse. Some healthcare practitioners recommend that patients more than 21 have a screening pelvic examination annually. Others recommend an interval of 3 years until age 65. However, no evidence support or refutes pelvic examination for asymptomatic low-risk patients. Thus, for such patients, the decisions about how often this examination should be done should be individualized. Neither a Papanicolaou test nor a human papillomavirus test is recommended for women more than 65 age who have had normal test results in the preceding 10 years. The genital area should be examined for signs of STI, others infection, and abnormalities. Joints are examined for tenderness, swelling, subluxation, crepitus, warmth, redness, and other abnormalities. Active and passive range of joint motion should be determined. The presence of contractures should be noted, whereas resistance to passive manipulation of extremities sometimes occurs with aging. Certain abnormalities, particularly those in the hands, may suggest specific disorders. Heberden notes or Bouchard notes osteoarthritis, subluxation of the metacarpophalangeal joints with ulnar deviation of the fingers, chronic rheumatoid arthritis, swan neck deformity, and boutonary deformity, also in case of rheumatoid arthritis. These deformities may interfere with function or usual activity. Common age-related joint findings include hallux valgus, medial prominence of the first metatarsal head with lateral deviation and rotation of the big toe, and lateral deviation of the fifth metatarsal head. Hammer toe and claw toe may interfere with functioning and daily activities. Toe deformities may result from years of wearing poorly fitting shoes or from rheumatoid arthritis, diabetes, or neurologic disorders. Occasionally, foot problems indicate other systemic disorders. For example, palpation of the dorsal pedis and posterior tibial pulses are important elements of cardio examination, and finding edema may suggest venous insufficiency of cardiac, liver, or kidney dysfunction. Patient with a foot problem should be referred to podiatrist for regular evaluation and treatment. Neurologic examination for older patients is similar to that for any adults. However, non-neurologic disorders they are common among older people may complicate this examination. For example, visual and hearing deficit may impede evaluation of cranial nerves and periarthritis, or certain joints, especially shoulders and hips, may interfere with evaluation of motor function. Signs detected during the examination must be considered in light of the patient's age, history, and other findings. Symmetric findings such as diminished ankle jerks and decreased distal vibration sensation unaccompanied by functional loss of the neurologic symptoms and signs may be noted in other patients. Clinicians must decide whether these findings justify a detailed evaluation to check for a neurologic lesion. Patients should be re-evaluated periodically for functional changes, asymmetry, and new symptoms. Cranial nerves. Evaluation of the cranial nerves may be complex. Older people often have small pupils. Their pupillary light reflex may be sluggish, and their papillary mitotic response to near vision may be diminished. Upward gaze and to a lesser extent downward gaze can be slightly limited. Eye movements when tracking an examiner's finger during evaluation of visual field may appear jerky and irregular. Bell phenomenon is sometimes absent. These changes occur normally with aging. In many older people, sense of smell is diminished because they have fewer olfactory nerves, have had numerous upper respiratory infections, or have chronic rhinitis. However, asymmetric loss of smell in one nostril is abnormal. Taste may be altered because the sense of smell is diminished or because patients take drugs that decrease salivation. Visual and hearing deficit may result from abnormalities in the eyes and ears rather than in nerve pathway. Uh, Patients can be evaluated for tremor during hand shaking and other simple activities. If tremor is detected, amplitude, rhythm, distribution, frequency, and time of occurrence at rest with action or with intention are noted. Older people, particularly those who don't do resistance training regularly, may appear weak during routine muscle strength testing. For example, during the physical examination, the clinician may easily straighten a patient's elbow despite the patient's effort to sustain a contraction. If weakness is symmetric, does not bother the patient, and has not changed the patient's function or activity level, it is likely to be due to disuse rather than neurologic disease. Such weakness is treatable with resistant training for the legs, especially it can improve mobility and reduce fall risk. Strengthening the upper extremities is also beneficial for overall function. Increased muscle tone measured by flexing and extending the elbow or knee is a normal findings in older people. However, jerky movements during examination and cowheel rigidity are abnormal. Sarcopenia is a common age-related finding. It is insignificant unless accompanied by a decline or change in function. Sarcopenia affects the hand muscle, in particular. Weak extension muscles of the wrist, fingers, and thumbs are common among patients who use wheelchairs because compression of upper arm against the armrest injures the radial nerve. Arm function can be tested by having patients pick up and eating a utensil or touch the back of their head with both hands. Motor coordination is tested. Coordination decreases because of the changes in central mechanism and can be measured in the neurological examination. The decrease is usually subtle and does not impair function. All components of gait should be assessed. They include initial of working, step length, height, symmetric continuity, and cadence, velocity, stride width, and walking posture. Sensation, musculoskeletal and motor control, and attention, which are necessary for independent, coordinated walking, must also be considered. Full risk assessment is recommended early for all adults age of 65 or older. Uh, Neurologic system. Normal age-related findings may include the following: shorter steps, possibly because muscles are weak or because balance is poor; reduced gait velocity in patient more than 70 because steps are shorter; increased time in double stance, which may be due to impaired balance or fear of falling; reduced motion in some joints; slight changes in walking posture in people with a gait velocity of less than 1 meter a second. Mortality risk is significantly increased. Gain and posture. Aging has little effect of walking cadence of posture. Typically, older people walk upright unless a disorder is present. Overall posture control is evaluated using the Romberg tests. Safety is paramount, and a clinician doing the Romberg test must be in position to prevent the patient from falling. With aging, postural control is often impaired and postural sway may increase. The deep tendon reflexes are checked. Aging usually has little effect of them. However, eliciting the Achilles tendon reflex may require special techniques. Uh, diminished or absence reflex present in nearly half of older patients may not indicate pathology, especially if symmetric. It occurs because tendon elasticity decreased and nerve conduction in the tendons along reflex arc slows. Asymmetrical heel tendons reflexes usually indicate a disorders. Cortical release reflexes, which include snout sucking and pulmomentary reflexes, commonly occur in older patients without detectable brain disorders. A Babinski reflex is older patient is abnormal. It indicates an upper motor neuron lesions after cervical spondylosis with partial cord compression. Evaluation of sensation include touch, cortical sensory function, temperature sense, proprioception, and vibration sense testing. Aging has limited effects on sensation. Many older patients report numbness, especially in the feet. It may result from decrease in size of fibers in the peripheral nerves, particularly the large fibers. Nonetheless, patients with numbness should be checked for peripheral neuropathies. In many patients, no cause of numbness can be identified. Many older people lose vibratory sensation below their knees. It's lost. It is lost because small vessels is not posterior column of the spine cord sclerose. However, proprioception, which is thought to use a similar pathway, is unaffected. A mental status examination is important for people more than 65 years or for younger people with concerns about cognitive decline. Patients who are distributed by such a test should be reassured that it's routine. The examiner must make sure that patient can hear. Hearing deficits that prevents patient from hearing and understanding questions may be mistaken for cognitive dysfunction. Evaluating the mental status of patients who have a speech or language disorders can be difficult. Orientation might be normal in many patients with dementia or other cognitive disorders. Thus, evaluation may require questions that identify abnormalities in consequentness, consciousness, uh, judgment, calculation, speech, language, praxis, execute function or memory, as well as orientation. Abnormalities of these areas cannot be attributed solely to age, and if abnormalities are noted, further evaluation, including a normal test and of mental status, is needed. With aging, information process and memory retrieval slow, but they are essentially unimpaired. With extra time and encouragement, patients do such tasks satisfactorily. Aging changes the interpretation of many measurements that reflect nutritional status in young people. For example, aging can alter height, weight changes can reflect alteration in nutrition, fluid balance, or both. The proportion of lean body mass and body fat content changes. Despite these age-related changes, body mass index is still useful in older patients, although is underestimates obesity. Waist circumference and waist to hip ratio have been used instead. Risk due to obesity and are increased if the waist circumference is more 102 centimeters in men and more 88 centimeters in women, or if the waist to hip ratio is more than 0.9 in men and more than 0.85 in women. If abnormalities in the nutrition history or BMI are identified through nutritional evaluation, including laboratory measurement, is indicated. Thank you for your attention.